Yeah, so we'll talk about sacral fractures, which ones need surgery, and what kind. And this really builds upon Paul's discussion. Because, so really I'll just be focusing on sacral fractures, but it's really difficult to separate sacral injuries from pelvic ring injuries. So if we take all pelvic ring injuries and take all sacral fractures, there's significant overlap, between the two, where you have pelvic ring injuries and sacral fracture components. And amongst these two, this Venn diagram, there are injuries that are stable and injuries that are unstable. Okay, and so we'll just sort of go through a couple of examples. So like this is an APC1 injury, just a sprain in the front. So this is a pelvic ring injury, but the sacral, there is no fracture of the sacrum. And this is generally a stable-ish injury. And then this geriatric LC1 injury, so an incomplete LC1 in our geriatric population, the majority of which are stable, treated without surgery. This has a sacral fracture. There's frequently an accompanying, anterior pelvic ring injury. But these, for the majority of patients in this demographic, are stable. And then we have injuries that just involve the sacrum, so almost like a high coccyx fracture. The pelvic ring is not disrupted. And so this is a sacral fracture without the pelvic ring injury. And then moving on to the unstable injuries, this is a patient where there is no sacral fracture, but the posterior ring is disrupted. You have bilateral SI joint widening. And so even though there is no sacral fracture, it's an unstable injury, as opposed to this vertical shear fracture through the sacrum. And then we also have, our U-type injuries, where the pelvic ring is still in continuity, but it's a fracture limited to the sacrum, and these are generally thought to be unstable. So for the rest of this talk, I'll just be focusing on just the nuances of sacral injuries. So really the blue part of the Venn diagram here. And so we'll take a step back. The purpose of the sacrum is really to transmit load from the spine down to the bilateral lower extremities. We think of the sacrum as a keystone in the Roman arch. And the sacrum, the issue is it can fracture in a number of different ways. So you can have fractures that go up into the end plate. You can have vertical fractures that may or may not involve the articular facet that's responsible for transmitting that load, or these vertical shear patterns. So how do we think about all of these? We also have this, we all know sort of about, U-type sacral fractures and their variants. The signature feature of these ones is there's a transverse component, so just keep that in mind. So the main objections for the remaining slides is just to understand the salient features of these injuries, discuss the clinical factors that guide treatment, and just because there isn't much of a place for us in the course to talk about it, is like which injuries may benefit from some sort of spinopelvic fixation. So for sacral fractures, there are two main buckets. I like to think of it simplistically as injuries where there's predominantly like a vertical component, and then other injuries where there's a transverse component. And there are different concerns that we have for each one of these injury patterns. So for the vertical patterns, what I look for is where it extends relative to the joint that connects to the lumbar spine, whether or not the hemipelvis is then translated, whether out laterally or vertically. If a patient has, if they have an unstable ring that then needs fixation, then we think about the bony corridors and the dimensions of those corridors for our instrumentation and what our weight-bearing goals are for the patient. Conversely, for our patients with a transverse injury, so you can see that, like this example here, the sacrum is tipped over, so it's kyphotic. And if it's left to heal in this position, there may be consequences down the line. You could see in the pattern like this, the sacral canal is compromised. The nerve roots passing through that area that namely control, bowel and bladder function could be compromised. So the neurologic function is something that we focus on. A lot of patients may not have motor deficits because the S1 nerve roots have already come out. So it's really that rectal exam that David highlighted earlier is critical for these patients. So when we talk about sacral fractures, there are a number of different classifications that have tried to categorize the fracture of the sacrum itself. The Denis classification is the first one. All of these classifications were later combined in a joint effort by AO Trauma and AO Spine into a more comprehensive system that captures everything. But this classification, really the main outcome that was looked at was neurologic injury. So for our zone 1 injuries, those had an accompanying a very low rate, about 5.9% of an L5 nerve palsy. That increased when you get to the zone 2 injuries that transected multiple foramen. The zone 3 injuries, when this was initially described, these were all grouped together. It turns out that the vertical zone 3s have an incredibly low neurologic injury rate, whereas the transverse ones have a much higher rate of injuries, which is not surprising. The Isler classification, again, this has not really been tied to many outcomes, but we think of it more from like a theoretical framework in terms of how that facet at the top is disrupted, because if it's displaced, then we think maybe we need to stabilize the junction, the lumbosacral junction. And then for our descriptive classification, for our transverse zone 3s, our U-type fractures, we sort of just describe these colloquially based on the shape of the fracture. But there is a subclassification that takes into account the amount of kyphosis and translation. This only plays a role if you're going to fix these, because it has implications for how we reduce these. Yeah, and again, with these, we're really looking at the sacral kyphosis and the canal compromise. And the reason sacral kyphosis is important is if this fracture heals in this position, now that this patient has sort of tipped over, in order for this patient to keep his head above his hips, his lumbar spine is going to have to compensate by an equivalent amount, which over time leads to pain, fatigue, and worsened functional outcomes. So that's why we try to fix these acutely. A common question that we get is when to call your spine colleagues for these injuries. These are, the majority of, pelvic ring injuries and these sacral fractures are very well treated by orthopedic traumatologists. But this, you want to get your spine colleagues involved if there's neurologic deficits, particularly bowel and bladder deficits, if there's significant sacral kyphosis, if there's a displaced facet fracture, or if you're considering additional fixation to get a patient up and walking and iliosacral screw fixation isn't sufficient to meet those weight-bearing goals. In terms of our operative treatments for sacral fractures, we have two broad buckets. One is iliosacral fixation, which is the mainstay of treatment in the contemporary era. And then posterior lumbopelvic fixation. And so we'll talk about the pros and cons of these. So for iliosacral screws, the pros are in well-trained hands, it's safe, it's minimally invasive. You could do it in either the prone or supine position. And for these vertically oriented fractures, because the screw is going perpendicular to the injury, you could generate fracture compression, which is great for union. The downside is they are not as adept at resisting shear forces if the patient's going to weight bear immediately. And you really need good fluoroscopic images in order to be able to place them safely. For spinal pelvic fixation, the historical literature was for open spinal pelvic fixation, but it can be minimally invasively placed now with advances in spine instrumentation. The main advantage is it offers superior resistance to flexion and rotation, which allows for immediate weight bearing. The cons is if you use an open technique, it's incredibly invasive. The rates of secondary surgery are in the 30–40%. It limits lumbar motion if you cross, L5S1, which accounts for the majority, a good portion of our lumbar motion. And depending on the technique, if it's poorly placed or if the screws are prominent, the hardware can be problematic and symptomatic later. And you have to do this in the prone position, which has implications for our polytrauma patients. We can combine these injuries, and so this is essentially a lag neutralization construct, right? So you have the iliosacral screw that compresses, and then you neutralize that construct. It's similar to our lag neutralization constructs for our long bone fractures. And so our goals of treatment are bony union of the injury and physiologic alignment. We want to optimize the potential for neurologic deficits. So if there is symptomatic neural element compression, you need to get those decompressed. And you want to minimize the complications with prolonged recumbency. So the factors that go into choosing a fixation strategy, I just asked myself 5 questions. First, is a neurologic decompression needed? If the patient's neurologically intact, the answer is no. If they have an acute caudate equina syndrome, then the answer is yes. How are we going to reduce the fracture? So a fracture like this, a non-displaced U-type fracture, it's already reduced. You're just preventing further displacement, so it's closed. Otherwise, you consider, percutaneous and then open, whatever you need to achieve an acceptable alignment. So this was a patient with that H-type injury, tried first to put some shank spins to control the fracture. That wasn't successful. Still has residual kyphosis, and then escalated the invasiveness and did an open approach and put a cob to directly manipulate the fracture to get our reduction. The other question is, do you need to fuse a lumbosacral junction? You only have to do this, you're doing this like very few times, and that's if there's a displaced facet fracture, where usually if this facet fracture is sort of nowhere to be found, then you need to stabilize that injury. And then how you're going to instrument really depends on the bone available for instrumentation and whether you are able to do so percutaneously or open. We're seeing more and more of these displaced or non-displaced U-type fractures in the setting of an aging population. Generally, when these are non-displaced, you could treat these with iliosacral screws as long as those screws are above the transverse component. So in that top picture, those are where you put the screws, where you can put it down to S2 if that transverse limb is lower. Our displaced U-type fractures, those are generally stabilized. We try to address the kyphosis. And again, this is just sort of showing just how we can percutaneously reduce those. So for spinal pelvic fixation, the absolute indications really are if you have an unstable lumbosacral junction, if the pelvic morphology precludes safe placement of our iliosacral screws, or if you have other hardware. This patient has one of the legacy implants that prevents in the mid-body of the sacrum. Our relative indications are displaced vertical shear components, where you're really trying to offset that shear component. If you're trying to supplement fixation to allow for immediate weight bearing in a patient you wouldn't otherwise let weight bear, or if they have corridors that are too narrow for you to safely place iliosacral screws. And of course, there's no reason to do this if a patient has a stable ring injury or with traditional fixation if they're able to tolerate a period of limited weight bearing or they can weight bear as tolerated. And so that's our summary. Thank you so much.